Whiskey 9, 7 November, interrogative Alpha Bravo. Negative Alpha Bravo. And this is 7 November Golf. Roger, request you check your Romeo side. I'll go ahead and check my Tango side. 7 November Golf out. November 8-5, and 8-5, 7 November, say again. Roger, 7 November, go. I copied a while ago, 1 Charlie transmission that my thing used, November, go, 1 Charlie, and 8-5, this is 7 November, Charlie. 8-5, right now. 1 Charlie, 7 November, go.
This is 1 Charlie, reference to your last, you're Brandon 158, extra 5 stops, 1200 between teams and local. Also request your unit take extra records to see if we can try to get Whiskey 9 and 8 for pause at the playground.
And this is 7 November, Roger, stand by.
Got that?
Got it? Alright. And all units, this is 7 November Golf. My unit Alpha, Echo, X-ray Alpha Alpha in there.
One Charlie, Alpha Bravo.
Hey, I never took a dip. I forgot to take a dip.
Whiskey 9, 7 November, interrogative Alpha Bravo. Whiskey 9, Yankee, 7 November Golf, over. Whiskey 9, go. Whiskey 9, 7 November, interrogative Alpha Bravo. Whiskey 9, Yankee, 7 November Golf, over. Whiskey 9, go. Whiskey 9, 7 November, interrogative Alpha Bravo. Negative Alpha Bravo. And this is 7 November Golf. Roger, request you check your Romeo side. I'll go ahead and check my Tango side. 7 November Golf out. November 8-5, and 8-5, 7 November, say again. Roger, 7 November, go.
All right, welcome back, everyone, especially if you were here for my earlier live stream. We did a Q&A. This live stream is different because we have an expert on board. It is Dr. Prashant Sharma. Introduce yourself here in a second. I just want to give the premise of this video. We have a Senate Veteran Affairs hearing where many people who really matter gave their opening statements. One of them is Daniel M. Gade, PhD, Lieutenant Colonel, retired. And he said things that I think everyone just kind of took as truth and no one refuted. And so we have a actual expert here, physician, board certified psychiatrist. Dr. Sharma, just go ahead and give your credentials. Like if you were on a in the courtroom, if you will, you know, why are you an expert? What do you got?
Absolutely. Thanks, Clay, for having me on. Yeah, so I'm a physician, which means I went to medical school and I was a flight surgeon in the Air Force for 4 years, chief of aerospace medicine during my last year in the service, deployed overseas as well. Got a lot of experience in medical conditions in folks in the military and their family members. And then after that, I got out and somehow I got into Johns Hopkins for psychiatry residency. So I wanted to become a psychiatrist. They took me in and I did that 4-year residency, graduated, and then worked in a bunch of different jobs, inpatient psychiatry, outpatient psychiatry, and then ended up starting to do independent medical opinions for veterans in these VA disability claims. I started that up in 2022, around the time that we connected as well. And yeah, it's crazy. And yeah, so that's what I've been doing since 2022. And in that, I obviously, work directly with veterans, but I work with multiple law firms, more than 3 law firms. These are accredited, VA accredited law firms who work with veterans on their cases. And so when this came up and this discussion came up and this hearing came up, I felt very strongly about it as well.
Yeah, so the hearing is about an hour and a half long, and it's going to be hard for me to just tailor my thoughts to one statement that was made, because I have many thoughts on just this one individual that we're about to see here. I'm going to try my best to keep those to myself, right? And focus on a single statement. And the statement that we're going to focus on, we're going to listen to a clip of his opening remarks, and then I'm just going to read the quote directly, and that's what we're going to refute line by line. And we're just going to jump into this here, Dr. Sharma. So let me turn up my volume because I totally forgot to do that. All right, here we go. This is the clip. It's about a 30-second clip.
2, disability compensation is a destructive goal. Disability is a negative word. In Latin, dis means not, opposite of, or apart. The disability compensation system pulls veterans into a destructive identity as, quote, disabled veteran, rather than helping create a positive, forward-looking life and career. This system is anti-thriving, anti-productivity, and ultimately anti-veteran. Further, it discourages future generations serving by painting veterans as a troubled problem class. The compensation system traps veterans into a disability identity, teaching them to chase 100% rating as a proof of honor or source of validation. 9 of the top 10 conditions for newly rated veterans are easily exaggerated or totally unverifiable. We need a system that...
Okay, there we go. So he said a lot there, and I'm going to try to ignore the previous things. But here's a quote, and I just want to pull it up so everyone can read it. This is his opening statement that he submitted to Congress, to the Senate. It says the compensation system traps veterans in a disability identity, teaching them to chase a 100% rating as proof of honor or source of validation. I'll keep those thoughts to myself here. 9 out of the top 10 conditions for newly rated veterans are easily exaggerated or totally unverifiable. Now, Doc, because I am who I am and I'm just so up in the VA space, we have the top 10 disabilities. This is the annual benefit report 2025. It comes out every single year. And if you look at most prevalent disabilities, you can do it by type and by period of service. I'm going to breeze through these really quickly. When you look at World War II, Korea, Vietnam, Gulf War, and peacetime, they're almost the same. So service-connected disabilities have almost been the same, extremely similar, for almost 100 years, right? Which is insane to think about, that there's not much difference when it comes to Vietnam era and the Gulf War era. It was just Vietnam in the desert, essentially, right? And so we have the top 10. What we're going to do is use these top 10 conditions right here. We have Dr. Sharma, who's going to give us his opinion on if these conditions are easily exaggerated or totally unverifiable. Because I'll tell you this, Doc, if these conditions are unverifiable, I think Daniel Gade, PhD, has a very solid argument, and the Senate and really Congress should really examine VA disability compensation. But if it's not, I also think that Daniel Gade, PhD, is being extremely disingenuous with the words coming out of his mouth. Anyways, I'm gonna try to stay PG-13 here. All right, so let's just start with the first one, Doc. We're going to skip tinnitus. I'm going to come back to that because that's going to involve changes. And then you look at verifiable. I would say 1 out of 10 of these would fall into that. I don't know about totally unverifiable, but at least there's an argument there. We're going to come back to that one. Limitation of flexion of the knee, musculoskeletal body system, Doc. Is that totally unverifiable? What do you have?
No, it is not totally unverifiable. It is verifiable. So, I mean, going back to my time as a flight surgeon, so this specifically even says limitation of flexion, right? Knee. So range of motion is most commonly observed through physical exam, right? So anytime you have range of motion in any of these conditions, you go immediately to the physical exam, you look at the veteran, you check how far they can actually do flexion of the knee, right? And however you want to do that, they can be sitting, they can be lying down, it kind of depends. But you can do that physical exam. You can verify, where they have pain and discomfort or stiffness or whatever it is causing that limitation in range of motion. You can also look at medical records, right? And you can assess changes in functioning over time. You can see like, oh, look, they had restriction of range of motion of this much at this time. And then it seemed to increase, with their treatment team over time. You can also ask them questions, have they had more difficulties doing things, mowing their lawn, doing physical exercise, picking up their kids, whatever it is. But it's absolutely verifiable. And this one specifically has range of motion in it. So that by definition, you can absolutely verify that.
So a question for you, because I know it's going to come, and I think the question is warranted because the statement made here is totally unverifiable. So got it. It's verifiable. Can veterans exaggerate symptoms? I think that answer is yes, like that's possible. My question isn't, can they exaggerate it? My question to you is, as a physician and board certified psychiatrist, how do you know or tell or suspect? How do you navigate, man, this guy's exaggerating symptoms? Like, what do you mean you can't bend it past 45, right? Because to my understanding, a CMP exam for the knee, you do it sitting or laying down, whichever. Unweighted is the main part. You do it unweighted, and then you stand up and you have a weighted, essentially, range of motion test. And then the examiner, from my Barney style understanding, is they can look at the expressions on your face. Because if you're in pain, unless you're psychotic, like you're going to show that you're in pain, right? So from your perspective, how do you go about identifying exaggeration and then navigating? Because I assume it's not the easiest thing in the world, because there's a lot of personality conflicts involved, or personality conflicts that can arise from saying, hey, are you lying to me, right? So what does that look like?
Absolutely. No, it's a great question. So yes, technically, like you said, it can be exaggerated by anyone, not just veterans, right?
Mhm.
And so that is a possibility. But exactly like you're saying, we would look at these different components, the person's facial expressions, how much resistance the knee has, right, at that motion, right, when you're doing the weighted exam or the non-weighted exam. You also try to correlate it with other things in the history, right? So if somebody says that, or somebody shows on physical exam that they can't flex their knee at all, let's say, right? And at the same time, they work in landscaping or something like that. And you say,
Yeah.
wait a minute. So how do you work in landscaping if you can't even bend your knee even 5 degrees or whatever? So there is this thing where you can sort of correlate it with other information. There's also this sense of whether or not the person is malingering, right? That's what they're trying to
Mhm.
say, or what he's trying to say is that veterans are malingering. That means trying to exaggerate for secondary gain, right? So for financial compensation. That is something that you can see on mental status exam, right? That's what we call it in psychiatry. We can look at the patient's facial expressions. We can try to see if they're exaggerating. It also comes with experience, right? Over time. When I was an intern, we often got prisoners from a local prison who would come in with different complaints, and we would try to assess that, right?
Yeah.
But I think it's also there's this sense that Dr. Date, he starts from a position that these veterans are lying, right? And veterans are just a microcosm of the entire population, right? And there is a less than 1% population who have these malingering tendencies, right? And so it would be the same in the veteran population as well. But again, without evidence kind of saying that this is happening at an extremely high rate, even though there's no evidence for that.
Yeah. And I think it also depends on what the claimed disability is, right? Like if you have in your service, in your service treatment records, I don't know why I was mixing that, in your STRs, okay? I say that word almost every day, by the way. In your STRs, if you have a knee condition, not I scraped my knee, right? If you scrape your knee and then all of a sudden you can't flex it at all, that's weird there. In fact, there's probably you probably need an x-ray because you didn't just scrape your knee, right? But if you have a serious documented medical condition of your knee in service, and then that would correlate, oh yeah, I could see how that would have a decreased range of motion. That's a big one there. Not to mention the most common rating for knees is 10%, right? Whenever you get to the severe side, that's when veterans need, and I'm saying this from a VBA perspective, that's when you'll see knee replacements. And once you're there, we're way past range of motion and knee strains, right? You're looking at knee replacements, 30% minimum on knee replacements. So do you have any thoughts on that before we move on to the next one?
Absolutely. You brought up a great point that I forgot, which is the inciting injury, right? Like, does it make sense with the inciting injury, right? Somebody hit their knee on the side of a door or something, you know, or whatever it is, versus an IED explosion or something like that. So absolutely. And once you get to that more severe level, kind of going back to what you said before, you have to kind of be psychotic if you're going to make that up and then go get a knee replacement, you know? And I think that's another level, and that probably is a psychiatric illness in itself if somebody's doing that, you know?
Yeah. Now I can't tell you the amount of times I've sat at a table where the legs come out, or I'm on the corner and my knee hits the edge of it and I feel like I want to cut my leg off. You know, it only lasts for about 5 seconds. Yeah, that sucks. Now this one is right up your alley. So number 3, top 3. Again, we're in the top 10 of GWAT veterans. The reason I chose GWAT veterans is because he also talked about new veterans. He talked about newly rated veterans, and so ideally that would be GWAT, which is weird because you could be a Vietnam era veteran and submit a claim today, and then you would also be a newly rated veteran. So I don't know, like, it's crazy to me how someone who is presumably really smart with a PhD would have these qualifiers that just make no sense at all. So I chose GWAT because he said newly rated, but it's really anyone who receives a rating. Like, we just helped a World War II veteran get rated, which is insane, by the way.
Wow.
So they're newly rated, right? And so it's like, how are we? I'm a big fan of words have meaning. And you would expect someone with a PhD, like that philosophical background there, would understand that words have meaning. Anyways, that's a small rant. The next one is right up your alley with PTSD. I know you're going to hit this one out of the park. Is PTSD exaggerated and totally unverifiable? Go ahead and take that in 2 parts because that's going to be a big one here.
Absolutely, yeah. So first of all, on the totally unverifiable, again, it's not totally unverifiable. I think one of the reasons why the VBA has such a system for verifying stressors is right there. That tells you it right there. You have to be able to verify the stressor. They will often, or at least sometimes, do an investigation into the stressor event itself. And if you do have documentation of the stressor, obviously the stressor at least is verifiable, right? Now, then we go to the PTSD condition itself, and this goes into the clinical interview, right? So meaning speaking to the person, the veteran, and we can do this by talking to them. We can have questionnaires. So a lot of VA clinics do these different questionnaires, PCL-5, PHQ-9, different things, and you can have a PTSD questionnaire, have them fill it out. That gives you additional data. You do the mental status exam, like I was saying before, where in each interview, we look, right? We see, like, all right, how's the person dressed? You know, what's their emotional expressions like? Are their emotional expressions constricted, right? They're not responding appropriately to jokes. Maybe they appear sad. Maybe they have blunted emotions, right? And are they groomed, right? So do they appear disheveled or unkempt, as we call it, right? And that's not judging anybody, right? That's can be a part of PTSD itself. And of course, we can look at the mental health records. So are they going to see therapy, a therapist or a psychiatrist or both? What are they talking about during these sessions, right? We look at the content as well. What are some of the symptoms being recorded? I realize not everybody goes to a therapist or a psychiatrist, but that's just additional data points that we can use. And yes, look, at some level, mental health psychiatry is, I hate to use the word subjective, but it is subjective in the sense that you have to talk to the person to find out how they're feeling, right? until somebody can create a mind reading machine, right? We're going to have to talk to people and ask them like, hey, how are you feeling? What's going through your mind? But we can talk to them, and we can talk to their spouse, one of their family members. We can look at the impacts the symptoms have on their lives, how it's limiting their income and their earnings potential, how it's led to problems in their personal relationships, right? And then you look at the whole picture. It's kind of like, I guess, not that I ever did Intel, but I think from what people in Intel tell me is you have this big chart and you connect all the dots, right? And you look at the whole picture and you say, does this make sense, right? And in psychiatry, we use the word congruent, right? So is the person, the veteran who's presenting to us, and the way that they're presenting to us, is it congruent with everything else we know about the veteran? So that could be medical records, that could be the stressor event itself. Does it make sense, right?
Mm-hmm.
Whereas, let's say, moving on to the exaggeration, right? So yes, it is possible to exaggerate, right? But again, we look at what's congruent. Now, let's say somebody has some mental health notes where they're going in to be seen by a therapist or a psychiatrist, and they're saying, I have very mild anxiety and no other symptoms whatsoever. But then during the CMP exam or the medical opinion exam, they say that they have thoughts of unaliving themselves or something like that, right? We try to assess, wait a minute, how did it go from here to there? I'm not saying that's impossible. It's just that we need to assess, does that make sense? And so for the small percentage of folks who might be exaggerating or malingering, we'll try to bring that up and we'll try to confront it and say, can you explain like how this worked, like how this went from this place to that place? There might be an explanation for it as well, but we can try to use that data as well. So I know I jumped around a little bit, but basically it goes through the interview, the review of the records, the mental status exam, what medications they're on potentially, right? Not that you have to be on medication, but that can give us additional data points as well. If somebody's being treated with 3 different medications, psychotropic meds, then that also signals like how much they're struggling as well. So.
I have a question, and this one, I don't know if you're able to answer it or not. Do you see, it's kind of similar to I scrape my knee, and then you would correlate that with, okay, well, you probably don't have a disability in the knee, like at least a chronic condition. You scrape your knee, it'll scab over, get over it. Like my daughter has a scraped knee right now versus someone who has less cartilage in their knee. I don't know knee conditions, right? It hurts, whatever. Do you see evidence in service or in-service stressors kind of correlate to how bad someone's PTSD is? So for instance, and the reason I'm confused on it is I have almost all of my friends have seen real combat, and not just once. It didn't just happen and we got lucky. I'm talking like many times over many month period, just constant combat. Do you but it affects everyone differently. Okay. In fact, one of my friends is I would label him as crazy, and I'm saying that in like a joking manner, not a medical manner, because this dude loves it, right? Like he loves it, and he really has no issues, right? Like the running joke is that there's a meme going around about Jim Mattis, who was a previous SecDef and has a Marine history there, how he makes the enemy lose sleep at night. He doesn't lose sleep. He makes the enemy lose sleep, right? And one of my friends has that mindset, whereas another person who was in the same situations, it affects them greatly, right? And so how are you able to take an in-service stressor of combat or viewing a death in training or MST? Do those correlate to how bad someone is mentally, or is it just like, is it everywhere? Because personal experience tells me it's everywhere, right? Even my own experience, I think I'm doing pretty good compared to a lot of my other friends, right? But it just depends on how you can handle it, I guess. What are your thoughts on that? I don't know if I like expressed that in a manner that makes sense, but...
Oh, it makes total sense. And it's a great question. So yes and no. So yes, the stressor event does tend to have an impact on the development of PTSD and the severity of PTSD, right? So, for instance, right, studies have shown that first responders who are exposed to the gruesome details of children, right, and injuries to children,
Yeah.
that has a very high rate of PTSD associated with it, right? Because that hits at something core inside of us. I think all of us, right? And maybe even more if you have kids. And so we can draw on that. And I often draw on that for first responders who are applying for PTSD to show that there is a connection between the stressor and the PTSD. However, what you said before is really important. So we all have a baseline personality that we start with, right? And this is how we are always, right? And since we were kids, we had this sort of baseline personality. And some folks have a little bit more neuroticism, right? They're a little bit more neurotic. They might be a little bit more prone to anxiety or depression. I'm not saying they had anxiety or depression or PTSD before the military, but they might be a little bit more prone. So that baseline personality gives a higher chance of having PTSD later, right? Or problems with anxiety or depression. So it kind of goes back to the point that it depends on the person, right? And whereas one person can see something really horrific happen, but they just move on with their lives and they never have any symptoms of PTSD whatsoever, versus another person who develops like full-blown PTSD and it affects every facet of their lives. It's not a judgment. It's not a weakness or a strength. It's just the way that our personalities are. I can tell you that I'm more neurotic at baseline, right? And that's sort of like a baseline trait for me. And so that's something that I always am cognizant of. And everybody has different traits like that we have to be aware of. So yeah, it has a huge impact.
It's pretty crazy seeing, and we're definitely going to speed it up here, but it's pretty crazy seeing one of my friends. I want to name him by name, but I didn't ask him before. This dude he's not a murderer. That would not be the right tone, but he would welcome killing the enemy for the country, right? And he loves it. Like, he is all about it. He was a machine gunner. It's just who this guy is. He is like a modern day warrior, and that's just what this dude's nuts. Okay. He's actually nuts. But mentally, like, he's thriving. You know, he's not dealing with SI at all, or any of the, you know, he doesn't struggle maintaining effective relationships with his children. The dude's just a psycho. And I'm saying that not medically, right? I'm just saying that because he's one of my friends. Anyways, I hope he watches this. He knows exactly what I'm talking about. All right, next one. And some of these are going to be very similar to just the musculoskeletal system. But if you could just hit on these fairly quick, unless there's anything new for sure. But what about lumbar or cervical strain? Is this easily, or not easily, I'm sorry, totally unverifiable and easily exaggerated? Lumbar or cervical strain. So we're talking about the spine.
Exactly. Yeah. So lumbar is the lower back, cervical is the neck. And again, it's not totally unverifiable. It is verifiable. So again, we go back to physical exam. So this is a musculoskeletal thing. So this one does not say range of motion in the title. It says strain, right? So we're going to look at something called pain on palpation. Palpation means when we press, right? So when I'm pressing on the person's vertebrae, you know, the spinal joints there, are they having pain? When I'm pressing on the paraspinal muscles, right? The muscles that go along the sides of our spine, is there pain? Is there tightness, right? I'm a DO, so I'm very much into the musculoskeletal system. And so we look at muscles and how they are, and we call it like bogginess, right? So some people will have like chronic problems in the low back or the neck, and their muscles will be boggy, right? They'll be kind of slower to move, right? They'll have a little bit more stiffness there. It's a little bit hard to explain, but so we look at that, and then we go back to range of motion as well. And we say, all right, so how much are they able to move their necks, left, right, up, down, all those different movements. And we look at the same thing in the lower back. And again, we go back to the limitations and activities, right? So are they limited in things they can do around the house, chores, physical exercise, right? I think one of the biggest things veterans tell me is that they used to use physical exercise to lift their moods, right, for the natural endorphins, and they're not able to do that anymore, right, because of these issues. And so are they limited in their physical exercise? Maybe intimacy with their partner, right? That's one that we can ask about. It's a private thing, but we ask about it because that has a huge impact as well. And also work, right? So we can also look and see, well, let's go back to the landscaper example, right? And the person loved their job, right? And they were excelled at their job, but they literally had to change professions, right? Because of this issue. They had to go work in an office and they hate it, right? And that has a huge impact on their mental health. It might limit their earnings potential, right? If they're not working as much. And so we look at the whole picture. Again, it's very similar to the other one with range of motion.
I think it's pretty different too with like lumbar strain specifically, and how the spine is rated. It's rated on two different schedules. You have range of motion, which is like overwhelming majority. I would probably say 98% of veterans are rated on range of motion. Then you have incapacitating episodes, and it's crazy to me that someone who, and this is an argument I hope to bring up if Gade comes on to the channel, which I really hope it happens. But something that's missing is like the date of diagnosis, right? A 23-year-old with IBDS in their spine, how is that unverifiable? How is that being exaggerated, right? I think age and date of diagnosis comes into play seriously, especially when you look at the entrance exam and the health of the service member applicant, right, as they entered the military. And then you look at the records of the military and you look at those correlations, especially for direct. If you're talking about the spine, 9 times out of 10 is going to be direct. Sources, trust me, bro. Okay. And then you look at the age and date of diagnosis, and there's no one on this planet. I'm not a doctor, but I don't need to know that a 23-year-old who has IBDS can't be verified or is exaggerating symptoms. It just blows my mind that's even an argument. Anyways, those are my thoughts on that one.
Absolutely. I agree. Completely.
The next one is, I would assume similar to the knee, but I definitely want to still hit it. Limitation of the motion of the arm. Again, in the musculoskeletal system, is this totally unverifiable and easily exaggerated? What do you have for that?
Yeah, again, it is absolutely verifiable. This one has range of motion in the name. So we're going to go back to the physical exam. We're going to do the same thing we did before. We're going to sit the veteran down. We're going to have him or her go through these motions, going to see where the limitations are, look at the expressions on the face. And also, going back to the inciting injury, does that correlate with the level of range of motion restriction? Do they have any abnormalities on their arm, right, from that initial injury and how it's limiting their range of motion? So we're going to look at the arm itself as well. And then we're going to look at the ways that they're impaired in their daily lives. Arms are a big one, right? Our hands, our arms, like those, I mean, it's critical. So it's going to be affecting different things in their life. So we're going to assess that as well.
Yeah. And again, when you look at a lot of these ratings, most lumbar cervical strains are like 10, 20%. You start to hit 30 for neck and 40 for lower spine once you hit that, the IVDS criteria, right? So to speak. That's just one diagnosis. There are like 50 billion. I don't really know them all. And it's the same thing for the arm. It's mainly 10, 20%. And anything above that, you might even be on the special monthly compensation scale, because imagine you can't move your arms more than this. That means you're not picking up your kids. That means you're not doing dishes. You're definitely not grabbing a bowl to pour your own cereal. You're definitely not reaching up to get milk. And so you see all these like really, really life or debilitating symptoms of your life. And it sounds like pouring a bowl of cereal is stupid, but imagine what else you can't do if you have some serious limitation, right? So just food for thought on that. Did you want to add anything? Yeah.
Yeah, actually, it's interesting. I'm looking at a case right now, which I'm not going to go too specific, for identifying reasons, but basically it's a neurological condition that's connected to service that affects the person's strength in both arms, right? And that's absolutely verifiable, again, because with neurological conditions, you can actually do measurements on it. But anyway, it affects everything, right? The way that they can interact with their family, the chores around the home, just everything. So that just reminded me of that.
Yeah, awesome. Okay, so a part of his statement, there is a footnote here that we're going to read. Usually it would like provide proof of what he's saying, but this one doesn't. That's another rant I have, but I'll keep that to myself. It says, of those, only scars or burns are readily identifiable and not subject to feigning or exaggeration. So this tells me, one, he took the time to write this. So this tells me that he didn't just accidentally write that. He put some level of thought into it, and then so much thought that he was able to kind of outlier scars and burns, which is a really long way to tell me that it makes this even worse, to be honest with you. But the reason I wanted to bring that up is because next are scars, but he's conceding that scars and burns are good to go in his book. Everything else, not so much. Anyways, let's go to migraine. Neurological. In my opinion, there's two rating systems that are the most difficult. It is cardiovascular and neurological. Migraines is like the easy neuro thing. Same with sciatica. When you start getting to like the TBI world, it gets really difficult, I think, medically and from a legal VBA perspective as well. Anyways, migraines, something that I deal with is probably one of the most debilitating things I deal with. Are migraines totally unverifiable, and can they be exaggerated? What do you got?
Yeah. So again, they are verifiable. Migraines are something that occurs inside the head, right? Inside the brain, technically. And so once again, we do have to ask the person how they're feeling. We do have to ask them about the symptoms that they're experiencing. At the same time, we can find out a lot by just talking to the veteran. There are regular headaches and then there are migraines, right? And there are certain migrainous characteristics that people have. Migrainous characteristics are like sensitivity to light, sensitivity to sound, nausea, vomiting, visual auras, things like that. And we look for those characteristics. And we also look for, where on the head the pain starts, and does it radiate to different places. And we look at all of these characteristics to try to figure out if these are migraines, are these tension headaches, are they regular headaches, right? And maybe they're not migraines at all. And yes, we do have to ask the person. But again, we're going to go back to that other thing, that concept of, is it congruent with everything else we see in the record, right? If the person is saying that they have 30 migraines a month, right? But they work full time as a CPA, and are not missing any work or anything, we're going to look at that.
That'll definitely give you some migraines as a CPA.
Exactly. I purposely chose that one. So we're going to have to look at that and be like, wait a minute, are the migraines lasting like 20 minutes? I mean, that'd be kind of odd, So there are things that we look for. And yeah, sometimes I do come across those cases. It's a very small percentage. I can tell you that right now. But when I do come across that, I ask questions and I try to get to the bottom of it. And if I don't think it's service connected, then I tell the person that, But at the same time, it is absolutely verifiable. We can also look at medications, what medications are being prescribed. Okay, so the person has sumatriptan, and they are also prescribed topiramate as a preventive, right? So we know that they have so many migraine headaches per month that an abortive medication by itself was not enough, that their physician actually ended up starting a preventive medication because it was happening too frequently. So that gives us an additional data point, right? And then we look at what other things they've been trying to do. So I have veterans who will tell me that they've tried different solutions. Like I know there's a solution that you like as well. There's cephaly, right? Different solutions that they've tried and they've been frustrated with because nothing's really worked. And we look at those as additional data points as well. Now, look, is it possible to exaggerate these things? Yes, it is, right? But again, we go back to, does it make sense with the rest of the picture? Do I really think it's at this level? Is it really having an impact on their job, right? Specifically with migraines, I think we come to a severe economic inadaptability, right? So that occupational impairment. Is it happening 8 times a month? And, this person works these shifts and all of a sudden he's dropping shifts, right? Because he simply can't go in to the job. And now it's limiting his earnings potential, right? Does it make sense with the whole story? And maybe the veteran can then present data from their job about how much time they're taking off or sick time or how many shifts that they're refusing. There's a lot, but we can look at the whole picture and see as well.
Yeah, treatment on migraines is a big one because as veterans, and I'm going to speak specific to male veterans right now, which is the overwhelming majority, but I don't want to, discount or downgrade female veterans at all. From a male veteran perspective, you can suck it up a lot, right? Like I've had knee pain. My knees are not service connected. They probably could be. Doesn't bother me one way or bit, but I have knee pain. I will suffer through it. Like I'm going to go trick or treating tonight with my kids. I'm going to pick them up. It's going to suck. I'll deal with it. Right. And I'm not going to go see the doctor about it because that's just who I am. And my assumption is that a lot of veterans have that suck it up mentality. When it comes to things like migraines, there's a difference between a headache and a migraine. I know there's different diagnosis. I'm just telling you from a feeling personal experience. A migraine will bring like the strongest grown man to his knees because there's nothing you can do. And at some point, Tylenol does nothing. You'll actually get like rebound headaches from that, which I've learned from my neurologist, right? And so there's these specific disabilities when you look at unverifiable that you can't suck up. I'm telling you right now, you cannot deal with migraines, especially once they get to a very high frequency. And we're not talking headaches at this point, right? And I know there's different types of migraines, but once you're on the preventative, I think it's like you're almost on a new level. It's like, okay, this person for real has migraines. Not to downgrade everyone who's not, but it's definitely like another level of treatment where it's like, okay, you're on preventative, got it. Here's a medication for the onset, got it. Here's this experimental solutions, got it, right? Like you're kind of on this like trifecta of, hey, I know this sucks. We're just going to throw everything at you to see what helps. And migraines is something that, in my experience, you just can't deal with it, right?
Exactly, yeah. And you're right. They throw everything, magnesium oxide, riboflavin, they're doing everything to try to stop these from happening. And they're absolutely debilitating. I don't have them, but I'll always remember, this is going back to like 2011 when I was a flight doc, but I'll always remember a pilot who had them that they just all of a sudden started up, right? Completely healthy guy. And this guy was never in the clinic. All of a sudden he is like in the clinic all the time. And in one of our exam rooms, dark, I'm pushing injections, like Toradol and all this stuff. And I'm like, wow, this is on another level. That was my first exposure, I think, to migraines in that way. And yeah, it's absolutely debilitating. And it ended up disqualifying him, and so it's huge.
I'll get a little personal here. We like dark humor in this house. And so my migraines were so bad one day. A few things happened prior to this. I won't get in that, but the result was high stress and then made migraines worse, which, by the way, is another thing. But I ended up in my own home. I put on my ear pro because I usually train with firearms at least like once a month. And so I have this like really expensive ear protection. I have like ear molds and then earmuffs. And I'm walking around the house with my earmuffs. My wife's making fun of me or whatever. And I was like, dude, I need to zone out right here. Right. And we have kids in the house running, screaming, TVs on, whatever. So it's something that you can't deal with so when someone tells me like migraines are totally unverifiable, my first thing is you have no idea what a migraine is, one. And you definitely never felt it, right? Because it will bring someone to their knees, for real. I'm not joking. Okay, almost finished here. We have a new body system, respiratory, is allergic rhinitis totally unverifiable. This one blows my mind, right? Because I know it's not. But I just want to hear you say it and how rhinitis is not totally unverifiable.
Exactly, it is not. So you can definitely verify it. I think that one especially, you can do a physical exam. You can look inside the nasal passages. And I know there are different levels and percentages depending on how bad the inflammation is in the mucosa, if there's any polyps, things like that. So you can literally do a physical exam, and then it goes back to the history, right? And I didn't say this before, but as physicians, right, like 95% of what information we get is from the history, is from what the patient tells us. And that's something that is drilled into you in medical school. And I remember one of our old professors would say that. He would say, just shut up and listen to the patient and just give them a few minutes to talk, right, without interrupting them. And they'll give you like 90 to 95% of the information. So I just brought that up because I forgot to say it before. But we go and we ask them, like, all right, how's the rhinitis affecting you? They tell us the level of nasal drainage they have, the congestion, the post-nasal drip, whatever it is. And then you can look at the medical records. You can look at medications. Are they getting Flonase? Is it escalating where they're having to try multiple medications and maybe an oral medication as well? So you can look at all of that. And this is one of the most verifiable ones as well.
Yeah, that's what's crazy to me is if you're gonna say something's totally unverifiable, which is like complete, at least be close. But it's so off mark. It's like, I don't know. As someone who has a PhD, I just don't know how you could use those words without backing them up. Anyways, that's another rant, and I'll stop right there because it'll just keep on going. When it comes to rhinitis too, something to think of is there's acute rhinitis. Like, not every diagnosis is chronic in nature, and so you have acute rhinitis. And if you have acute rhinitis and you meet PACT Act requirement, you've been to Afghanistan 30 times, acute rhinitis is not going to be service connected because it's not chronic, and people just kind of forget that. And then even if it is chronic, but your symptoms have been treated, and so therefore you don't have any symptoms, but you have this diagnosis, that's a good old fat 0%, right? So what are we even arguing about here? It's the 10% with I forgot what the 38 criteria is. It's something about nasal passage and 50% blockage. And then you have the polyps, which polyps is 30% rhinitis is quite rare. And I'm saying that from a VBA perspective, right? Because ideally you would be on some sort of treatment plan and you don't want polyps. That's not something you want, right? It's not worth the 30%. So it's just crazy to me that the words coming out of his mouth, and it's not on Facebook or Reddit. It's to the Senate, by the way. That's the big part, right?
And it's taken at truth, at face value, without verification.
It's like, oh yeah, I guess 9 out of the top 10 disabilities everyone's faking. It's like, hold on.
In fact, you can say his statement is totally unverifiable.
Yeah, exactly. Okay, last two here. Limitation motion of the ankle, again on the musculoskeletal body system. Doc, what do you have for that?
Yeah, same as before. We're looking at the physical exam. We're getting the veteran down on the table, like, hey, take off your shoes, your socks. Let's look at the skin around the ankle. Let's look at the range of motion. This one has range of motion in the title. So we're looking at the dorsiflexion. We're looking at the different ways that the ankle can move, basically. And we're looking at how limited it is. We're looking at the facial expressions of the person. Are they in pain? We're looking at just, any sort of discoloration around that area. I think that's more with like acute injuries. So not like chronic, but you never know. So you can look at that area as well. And then we go back to the history. What was the initial injury? It doesn't have to be an injury, right? Certainly, as you Marines know, like, you guys do high impact activity day in and day out, and that in itself can cause joint problems. So we look at that type of history and see, and then we look at the limitations in their life, and then we also look at medications. Are they slamming Motrin, right, 3 times a day, 4 times a day, and we look at all of that. So it's very similar to the other ones with musculoskeletal.
All right, and the last one, and I got something in my back back pocket that I've been saving that I'll bring up after this. Paralysis of the sciatic nerve. So we're talking about, most veterans know this as radiculopathy. That's just the most common type of sciatica. There are different ones. Let's just stick with radiculopathy because I think that's going to resonate best with the audience here. But it is the sciatic nerve. Again, in the neuro body system. Doc, what do you have for that? Is that verifiable?
Yes. Again, it's verifiable. I think with sciatic nerve pain itself, or radiculopathy, one of the most common things is the straight leg raise test. So there's like sort of a test that you do as the evaluator, and you see if, when you do that test and you raise the person's leg in a particular way, you see if that there is pain. You ask them if there's pain, and then you also look at their facial expressions to see if there's pain as well. And then you go back to the history and ask, where is the pain, right? Is it radiating down the back thigh, shooting down? When does that happen, right? What types of motions do you do when that happens? And then you look and see if that correlates to sciatica, right? Is that a type of motion that would exacerbate sciatica or not? And then you go back to the history. You say, okay, well, they have a history of lumbar strain, or maybe intervertebral disc syndrome, or degenerative disc disease. So that's going to make them more likely, if they have something involving the lumbar area, that's going to make them more likely to have sciatic nerve pain as well. And then you go back to medications as well. So it's kind of similar, just a little bit different because there's a name for the test for that.
Yeah. And what's cool about the body systems here is neurological is getting has proposed changes specifically to how CMP examiners and the DBQ are going to test for nerve damage. It's got something to do with gravity. That is way above my pay grade. I just know there's like levels of gravity. They're going to deal with it. I don't know. And then the last one here, tinnitus. When it comes to unverifiable, I think there is, and I definitely want your opinion, I think there is an argument to be made that tinnitus, whatever, I'm sticking with tinnitus until I die, that it is unverifiable, right? Is there a way to verify ringing of the ears apart from the veteran saying they have ringing in their ears?
Right. Yeah. So, I mean, you can argue this one, right, that it is subjective, that you do have to ask the person, if they're having tinnitus. It's not something that you can detect like on a hearing test, right? Meanwhile, hearing loss or those other things you can. So yeah, I wouldn't say it's totally unverifiable because, again, I go back to the history part, right? And asking the veteran and seeing if it makes sense, right? Have they talked about their tinnitus before, right? Or have they gotten seen for the tinnitus? There's a lot of ways that you can also go and try to verify it. So that's a big thing. I think the other thing is like just having talked to so many veterans with tinnitus over time, and they describe to me the level of distress, that they have from it. It's insane. I mean, it's so bad for some people that they've either done or considered doing a surgery to dilate the eustachian tube, to widen the ear tube, and to get rid of the tinnitus. Veterans have spent hundreds of equipment to distract themselves from the tinnitus: white noise machines, fans, earbuds, or ear pros. And yeah, so it has a huge impact. I just wanted to mention that because it's like, let's not underestimate it either. Like, yes, it's not as verifiable as some of the other things, but it does have a real impact on people.
And we know tinnitus is being deleted from the diagnostic code in 38 CFR. That's going to happen probably, and I would assume relatively soon, especially after that Senate Affairs hearing, because it was brought up that there's 4 body systems that haven't been changed. That's one right there. There's one right there. And that's one, and that's one, right? And so we see the top 4 on the 4 body systems that haven't been updated in the top 10. So I think it's going to happen pretty soon. But when you look at tinnitus, it's being deleted because it's from what I understand, a symptom of an underlying condition. But that also leads me to think is, okay, well, someone with tinnitus, do they have hearing loss? And experience in the military relate to that, right? Like a mortarman or someone who is in artillery, does that relate? And then you look at other inner ear problems or vertigo or dizziness, someone who has tinnitus, right? I can tell you sometimes when not all the time, but sometimes it's kind of like not blind, but there's definitely blurriness vision. I hear nothing. It's like I'm deaf for about a split second. And then the tinnitus kind of ramps up. And then it slowly dies out. And I'm having this like, almost like I'm fainting, but it's not. It's like I'm coming to, but I never fainted. And this can happen while I'm driving. It happens whenever. I don't know what causes it. But then you think of like it's not just ringing in the ears. There's like inner ear issues. There's hearing loss. There's, on the neurological TBI side of the house, which is way more severe. You have all these like other factors that you can say, you know what? I think you got tinnitus, right? And so I think there is a way to verify it. But when you have an administrator who doesn't have anything in their records, when I say administrator, I mean that they were admin, they were a clerk, in the S1 shop, whatever, who claims tinnitus, I think there's an argument to be made there, given the fact that even their deployed experience, because trust me, we've had admins and cooks in our patrols, because they want to go out sometimes, they're stuck on the patrol base for 6 months, and they're like, hey, Sergeant Sims, can I, do you mind if I tag along on this patrol? And I'm like, sure, whatever, hop in, just to give them some fun. So there are occupational hazards outside of your normal MOS. But again, that's like a 1-day thing. I would probably want to see like exposed long-term exposure, right? For whenever you look at like something like tinnitus with that background. Anyways, do you have any thoughts on that at all?
No, yeah. And what you're describing there with that sensation, that whole episode that you just described, a lot of people will tell me that with variations, obviously, right? There's like subtle different characteristics. Some people, it'll almost be like post-explosion, right? That kind of, like that hearing loss post-explosion and then leading to the ringing in the ears. And so I don't have much to add other than that. I've heard that type of thing before, but with variation.
Yeah, it's very weird. And my wife is next to me. She'll be like, what's going on? It's like, you don't get it. I'm not even going to try to explain it because you're not going to get it. And even if you do get it, you're not going to believe me. So just don't worry about it.
Yeah. Yeah, no, exactly. Oh, yeah. And you just reminded me, there's also in the scientific literature now, when somebody experiences a migraine headache triggered by tinnitus, it's actually called a cochlear migraine. And the cochlea is a part of the ear. So that just tells you how significant it can be.
Yeah. And the last thing, first, I want to thank you for your time, Dr. Sharma. It's great to have you on, as always. If you don't know, when I first started this YouTube channel, Dr. Sharma was in a Facebook group. He was kind of starting his Nexus letter, independent medical opinion journey as well. I was like, hey, man, we should link up. And it's been great ever since, right? So seriously, thank you. You're definitely a day one person, and I see a lot of day one fans in the chat too. I do want to highlight some people who have commented. First, Jared H, thank you for being a member. I definitely appreciate it. And same thing with you, Arthur Walker. Now AF vet, so I assume he was in the Air Force. So aim high or whatever it is you guys say. Gade said PTSD is curable as his argument that it shouldn't be rated into PTSD. I know you have thoughts on that one. Let me go back to this one. All right. I didn't read it before. We're going to circle back. We'll actually end with that. All right. Jesse, thank you very much. Says, I'd love to sit down with Gade and talk. Yeah, we don't use bad words here, but I definitely understand what you're saying. All right. Thank you. And then BF, thank you very much, by the way. It says, to the chat, these guys are great. Dr. Sharma has completed 2 successful DBQ, Nexus, mental health, and sleep apnea for me. I will have the info next week for my IBS doc. Thank you so much. So Dr. Sharma's awesome. Okay. The amount of veterans you've helped are untold. Even the veterans who haven't used your Nexus letter service, they get the information secondhand through videos. You have your own channel. So if you don't know, you should go to Concise Psych youtube.com/@concisepsych. I believe is what it is. Okay. And then you can absolutely check that out. And then you have your website, concisepsych.com, and you'll find that down below in the description. Now, Doc, this is a big one here. So let me just give you my non-medical opinion on this one. Do I think PTSD is curable? I won't use that language. I think some severe symptoms can be managed in a manner where they're not severe anymore. What I mean by that, right, is you may have extreme trouble maintaining effective relationships with your family. Kids, to be specific, especially if, like, when we were in Afghan, we had a lot of, we call them chai boys, right? I won't go into it. You could just Google chai boys and just probably go incognito mode, to be honest with you, if you're going to do that. But it's essentially legalized sex trafficking, rape of little boys. That's what it boils down to, right? And so you could imagine someone would have trouble maintaining an effective relationship with their 6-year-old son that they're going to go back home to. And that can be managed in a sense where the veteran can have a healthy, father-son relationship there, but it takes time. Also, whenever the time has passed and the relationship is healthy, at a moment's notice, it can, I think it can revert back. It takes one thing to happen to kind of get back in your rut. I always describe mental health like this. It's kind of like you're in a swimming pool. Some days you're on your floaty, you have your drink beside you, you're above the water, the sun's out, it's partly cloudy, so you're not burning up. It's a good day. There are some days where you're just like treading water, like you're not going to drown, but it sucks. And you can't express it to anyone because you gotta take the kids to school, you gotta pick them up, you gotta do whatever else. And some days you're drowning, and that's how I would you're not cured, you're just good that day. And then same thing on the drowning side. It's not that your life is over, you're just having a bad day is a bad way to explain it, but you can get out of the rut, but it's not gone forever. That's my take on this. I think the answer is yes. I think it's also no. I think there are two truths to that, personally. Now, I'm not a board certified psychiatrist. We're going to end it here, Doc. What is the answer to Gade saying that? And I don't know if you watched his hearing. I'll pass it to you real quick. I should have started with this. In his hearing, he talked about how a lot of disabilities are curable, and he specifically called out PTSD and said, his whole argument is that veterans get a rating for PTSD and they don't want to get better. I do think there's an argument there. That's its own separate video, right? When you have incentives to not get better or healthier, I do think that's an argument. I just think his backing forward is so jacked up, it's wrong. Anyways, is PTSD curable? What do you think?
Great question. And I just wanted to mention one other thing that somebody said in the chat is that just to point out, Daniel Gade, right? He's a PhD. He's not a physician. And I'm not trying to be like, oh, physicians are better or anything. I just mean that to highlight that he does not have that medical knowledge or psychiatric knowledge, right? So he's worked as a professor in public affairs, I believe, mainly, right? So again, we have to kind of remember that he's not technically an expert, right? When it comes to these topics. So anyway, right. So this is a great question. So the answer, exactly like you said, and I think the way you described it is perfect. It is yes and no. Yes, we can get to a point with certain cases of PTSD where the person does not have any symptoms whatsoever, right? That is possible, right? With or without medication. Maybe we're going to do therapy, EMDR, maybe exposure response prevention, whatever it is. But unfortunately, I think that is a small percentage of folks. I think most people continue to deal with PTSD symptoms for a really long time. People who've taken my course on anxiety, depression, PTSD in veterans will know that I talk about my own past as well in that course and what I've struggled with as well. And I think it's something that stays with you, okay, over time. And like you said, there's ups and downs, right? Sometimes it gets better, sometimes it gets worse. Now, just the fact that it is theoretically curable, why should that be that it shouldn't be rated, right? That's what I don't understand, right? So, for instance, there are different types of cancers that are curable in the sense that they can go into remission, right? But does that mean that they should not be ratings at all, right? Especially if the person went through chemotherapy or all these different types of treatment for it and have other problems from it. Similarly, with PTSD, when you say it's curable, do you mean that it's cured and the person is on 3 medications, right? That then cause the person to have metabolic syndrome, weight gain, hypertension, sleep apnea, and then all of a sudden it causes this cascade of issues. There's a reason why studies show over and over again that people dealing with mental illness, especially moderate to severe mental illness, don't live as long as people without mental illness, right? There's a reason for that. It's not because these things are just trivial, but these things have huge impacts on people. So it's not a yes or no, but it's definitely not what he's portraying it as, I would say.
Yeah, and it's definitely not. Hold on, I want to get this quote right because it just blows my mind every time. PTSD is definitely not easily exaggerated, and it's 100% not totally unverifiable. In fact, the M21 TAC 1 standard is verified stressor, which is just, it's almost like he doesn't know what he's talking about. Anyways, Doc, go ahead.
I just have one thing, and I hope you're okay with me saying this.
Absolutely.
For veterans who are interested in, if you want more background on Daniel Gade, you can go into ChatGPT. Okay, if you do deep research, it's even better, but you can do it on a free account, and you can ask who he is paid by, okay, who contributes money to him. And in his past research articles, what financial disclosures did he have, and what organizations contribute to him who are politically motivated to have certain ideologies. And I'll just leave that to you. You can do your own research and look at the facts on that as well.
Yeah. Maybe I'll post that video after he agrees to come to the studio, right? But I hope he does. And I'll say this too, because I've seen a lot of, I don't know if you looked at my channel the past day, but I made 3 videos on the Senate hearing. The comments are wild, okay? And so I just want to say this to veterans, right? Even though this dude disagrees with us, keep in mind that, like, you're on my channel, it's almost like an echo chamber. We get a few outliers in the comments of people who disagree, but whatever, don't worry about that. But it is an echo chamber in here. Don't be fooled. Like, if you go to his platform, that is also its own echo chamber, and we are not in agreement. And so I say that because if he does come on the channel, I'm probably going to disable chat just so I can talk to this guy and have a cordial, grace-given conversation. And I'll describe it like that. But yeah, there's people who have serious influence who heard what he said. And his opening statement isn't even the worst of it. Okay, it gets way worse after his opening statement. But there's people who really matter and has high circles of influence that heard what he said and was like, you know what? Yeah, 9 out of the top 10 disabilities that all veterans are rated for are totally unverifiable. We should do something about that. And no one questioned him about it. They were just like, oh, okay. And so whenever I heard him say that, I was like, there's no way someone is going, like, they're not going to let that slide, but they did. And so that really matters. So that's all I got. Go ahead.
And it's shocking to me, like you said in the video, that only one person defended us, right? Defended veterans at large. And it doesn't matter what political party, whatever, it doesn't matter. But there was just that one person, right? Tammy Duckworth, I believe, who defended veterans, which is mind blowing to me that nobody else did.
Yeah. Well, Doc, I want to thank you, for everything, really, but specifically this live stream. It's good to get an expert witness to actually talk about the top 10 and give an opinion that actually matters versus, words. Do you understand the words that come out of my mouth? That's what the 90s in me is screaming right now. But yeah, if you don't know Dr. Sharma, go to concisepsych.com. You'll find all his stuff there. He also has his own YouTube channel, youtube.com/@concise psych. You just put in concise psych. This beautiful man here will pop up. Go ahead, subscribe, like all his stuff. And yeah, that's all I got, Doc. Thank you very much. I appreciate it.
Anytime, Clay. And thank you for having me. And thanks for everything as well.
Yeah. All right.